Today I'll be talking about drugs for type 2 diabetes. Key points: treating to a target hemoglobin A1C of less than 7 while minimizing hypoglycemic episodes is recommended. Metformin is generally preferred as the initial drug of choice. Most patients do require multi-drug regimens to achieve their hemoglobin A1C level. Patients with atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease may benefit from addition of SGLT2 inhibitor or GLP-1 agonist. Preferred anti-hypoglycemic drugs based on patient's condition. Patients with atherosclerotic cardiovascular disease, the preferred drug of choice is GLP-1 receptor agonist or SGLT2 inhibitor. Patients with heart failure and chronic kidney disease, the preferred drug of choice is SGLT2 inhibitor. Patients who are overweight, the preferred drug of choice is GLP-1 receptor agonist or SGLT2 inhibitor. Patients who need substantial hemoglobin A1C reduction, the preferred drug of choice will be insulin, sulfonylurea, GLP-1 receptor agonist. In order to minimize hypoglycemia, the preferred drug of choice would be biguanide, DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitor, or thiazolidinediones. Metformin, it belongs to the class of biguanide. It is preferred as the initial drug of choice for type 2 diabetes. It decreases hepatic glucose production and increases secretion of GLP-1. It also reduces intestinal absorption of glucose and increases peripheral glucose uptake. It reduces hemoglobin A1C by 1 to 1.5%. It does not cause hypoglycemia except when combined with sulfonylurea or insulin. It is weight neutral. In terms of cardiovascular outcomes, it reduces risk for MI and all-cause mortality. It is contraindicated with eGFR less than 30. It is not recommended to start on metformin when eGFR is less than 45. Some of the adverse effects include GI, such as metallic taste, nausea, abdominal cramps, diarrhea, possible vitamin B12 deficiency, and rarely can cause lactic acidosis. SGLT2 inhibitors, which stands for sodium glucose cotransporter 2 inhibitors, such as canagliflozin, dapagliflozin, empagliflozin, decrease renal glucose reabsorption and increase urinary glucose excretion, thereby reducing fasting and postprandial blood glucose levels, reduce hemoglobin A1C by 0.5 to 1%. They do not cause hypoglycemia except when receiving insulin or a sulfonylurea. In terms of cardiovascular outcomes, they do reduce risk for major adverse cardiac events in patients with atherosclerotic cardiovascular disease. They also reduce the risk for hospitalization of patients with heart failure. They slow the progression of chronic kidney disease, reduce risk of end-stage kidney disease. Dosage adjustment is required based on the eGFR. Adverse effects include genital mycotic infections, urinary tract infections, volume depletion causing acute kidney injury, normoglycemic diabetic ketoacidosis. GLP-1 receptor agonist, also known as glucagon-like peptide 1 receptor agonist, such as dulaglutide, exenatide, liraglutide, semaglutide. They potentiate glucose-dependent secretion of insulin, suppress glucagon secretion, and slows gastric emptying, reduce hemoglobin A1C by 1 to 2%. They tend not to cause hypoglycemia except when used along with insulin or a sulfonylurea. They tend to cause significant weight loss. Semaglutide, also known by brand name Ozempic, has been in the news for this reason. In terms of cardiovascular outcomes, it reduces the risk for major adverse cardiac events in adults who have atherosclerotic cardiovascular disease. They do not reduce hospitalization of patients with heart failure or slow the progression of chronic kidney disease. No dosage adjustments is required based on the eGFR for dulaglutide, liraglutide, or semaglutide. Avoid exenatide if GFR is less than 30. Adverse effects include mostly GI, such as nausea, vomiting, diarrhea. There is a possible risk for pancreatitis. They are contraindicated in patients with personal or family history of multiple endocrine neoplasia type 2. DPP-4 inhibitors, which stands for dipeptidyl peptidase TYPE-4 inhibitors such as elogliptin, linagliptin, saxagliptin, sitagliptin potentiate glucose-dependent secretion of insulin and suppress glucagon secretion, do not have any positive or negative effect on the risk for major adverse cardiac events or preventing hospitalization for heart failure or progression of chronic kidney disease. Reduce hemoglobin A1C by 0.5 to 1%. They tend not to cause hypoglycemia except when used with insulin and sulfonylurea. They are weight neutral. A dosage adjustment is required based on eGFR except for linagliptin. Adverse effects: there's possible risk for pancreatitis, fatal hepatic failure. Sulfonylurea such as glimepiride, glipizide, glyburide increase insulin secretion independent of nutrient intake. They tend to decrease hemoglobin A1C by 1 to 1.5%. They tend to cause hypoglycemia and weight gain. Dosage adjustment may be needed based on eGFR with glipizide and glimepiride. Adverse effects include hypoglycemia, which is more common with glyburide. Thiazolidinediones such as pioglitazone and rosiglitazone, which is currently not available in the US, increase the insulin sensitivity of adipose tissue and skeletal muscle and reduce hepatic glucose production. They reduce hemoglobin A1C by 1 to 1.5%. They tend not to cause hypoglycemia. They do cause weight gain. In terms of cardiovascular outcomes, they reduce the risk of major adverse cardiac events in patients with atherosclerotic cardiovascular disease. They also have a benefit in patients with non-alcoholic steatohepatitis. No dosage adjustment is required based on GFR. Adverse effects: risk of pancreatitis, possible risk of bladder cancer, and increased risk of heart failure, and are contraindicated in patients with New York Heart Association class 3 or class 4. Pregnancy. Metformin appears to be relatively safe for use in pregnant women, but insulin is the drug of choice for treatment of type 2 diabetes in pregnant women because it does not cross the placenta. Insulin and metformin are generally considered safe for use while breastfeeding. Data on the safety of other antihypoglycemic drugs during pregnancy is insufficient. Dosage of antihypoglycemic drugs. Biguanide. Metformin usual dose is 1500 to 2500 milligrams divided twice daily. It comes in extended release version, which is given in the dose of 1000 to 2000 milligrams once daily. SGLT2 inhibitors canagliflozin is given in the dose of 100 to 300 milligrams once daily. Dapagliflozin given in the dose of 5 to 10 milligrams once daily. Empagliflozin given in the dose of 10 to 25 milligrams once daily. GLP-1 receptor agonist dulaglutide is given as 0.75 to 1.5 milligrams subcutaneous once weekly. Axanatide given as 5 or 10 micrograms subcutaneous BID. The extended release version is given as 2 milligrams subcutaneous once weekly. Semaglutide is given in a dose of 0.5 to 2 milligrams subcutaneous once weekly. Liraglutide is given as 1.2 or 1.8 milligrams subcutaneous once daily. DPP-4 inhibitors. Elogliptin given in a dose of 25 milligrams orally once daily. Linagliptin given as 5 milligrams orally once daily. Saxagliptin given as 5 milligrams orally once daily. Sitagliptin given as 100 milligrams orally once daily. Sulfonylurea. Glipizide given as 10 to 20 milligrams orally once daily or divided twice daily. Extended release called as glucotrol XL given as 5 to 20 milligrams once daily. Glimepiride given as 1 to 4 milligrams orally once daily. Thiazolidinediones, pioglitazone given as 15 to 45 milligrams orally once daily.